Welcome to today's briefing, Medi-Cal Explained, Waivers and State Plan Amendments. I am Chris Perrone, Director of Improving Access at the California Healthcare Foundation. The California Healthcare Foundation is dedicated to advancing meaningful and measurable improvements in the way the healthcare delivery system provides care to the people of California, particularly those with low incomes. Strengthening Medi-Cal, the cornerstone of our safety net, is a priority of ours. The Department of Healthcare Services is about to launch the California Advancing and Innovating Medi-Cal, or CalAIM initiative, which seeks to drive delivery system, program, and payment reforms to spur improvements throughout Medi-Cal, including in managed care, behavioral health, and dental services. This process will include planning for the next Section 1115 and 1915B waivers. Federal waivers, where the federal government is waiving specific restrictions in federal law governing Medicaid, play an important role in Medi-Cal, bringing additional federal resources to the program and allowing for critical innovations in the delivery of care. Over the past 2 decades, California negotiated a series of groundbreaking waivers that have, among other things, allowed the state to expand coverage to millions of Californians, to improve access to outpatient care and reduce avoidable hospitalizations, to reduce disparities in care, and to better coordinate care for Medi-Cal enrollees with complex medical, behavioral, and social needs. Another avenue for advancing reforms identified through the CalAIM process is by amending the state plan for the Medi-Cal program. The state plan is the contractual agreement between the state and the federal government that describes the nature and scope of the Medi-Cal program. State plan amendments, or SPAs, reflect program changes, corrections, or updates to the state plan. In preparation for CalAIM, today's webinar will provide a high-level overview of waivers and SPAs and how they differ. We will also review how California has previously used waivers and SPAs, including a refresher on what's in the current 1115 and 1915B waivers. Though Medicaid policy is famously complex, we will try to keep today's presentations simple and clear, the freshman introduction rather than a graduate level course. I'm delighted that we have 2 nationally renowned experts joining us today, 2 people who are certainly capable of teaching a graduate course in Medicaid policy. Our first speaker is Cindy Mann, partner of Manat Health. Cindy is the former Deputy Administrator of the Center for Medicare and Medicaid Services and former Director of the Center for Medicaid and CHIP Services, where she oversaw state Medicaid programs and the review of state requests for federal waivers during a time of remarkable transformation and innovation in Medicaid. I've been fortunate to work with Cindy on several engagements where her expertise and insights have led to sound recommendations for transforming Medi-Cal to better meet the needs of Californians. Cindy will provide a high-level overview of waivers and SPAs. Our second speaker is Jennifer Ryan, Executive Vice President of Harbage Consulting. Jen is the former Director of the Intergovernmental and External Affairs Group for the Center for Medicaid and CHIP Services, and like Cindy, now works with states around the country to improve their Medicaid programs. Jen is a lead consultant to DHCS for CalAIM, providing project management, technical expertise, and expert insights. Jen will provide a high-level overview of California's current 1115 and 1915B waivers, which expire in 2020. Following presentations from Cindy and Jen, we will have time for questions and answers, followed by closing remarks from my colleague, Catherine Tier, Associate Director of our High Value Care Program. To submit a question to our speakers, please use the chat box. We will do our best to get to as many questions as time allows. If you have technical difficulties, send us a message in the chat window and our technical team will assist you. If you're not viewing them already, you can find the slides for today's presentations in the meeting documents section on your screen. They are also posted on the CHCF website, together with 2 short papers explaining waivers and SPAs. Within a few days, recordings of this webinar will also be posted on our website. We hope this webinar is useful and encourage you to complete an evaluation at the end. With that, I am pleased to hand things off to Cindy Mann.
Which is to explain in exciting ways, state plans and waivers and the waiver process a little bit more deeply in a general way to give everybody the background needed as a prelude to Jennifer's presentation, which is what's been happening in California on state plans and waivers in particular, and what are the opportunities ahead. So with that, let me just briefly let you know what, if you go to the next slide. I'm sorry, I can't see the slide, so perhaps you are there. I'm going to cover a little bit just Medicaid governance and financing. Then I'm going to talk about those authorities that Chris identified, state plan, 1915 waivers and section 1115 waivers, and then do a little bit of a deeper dive on section 1115 waivers because they are more comprehensive and potentially have greater opportunity for diverting from the normal rules of the Medicaid program. So let's start. I think all of this needs the backdrop of how is Medicaid structured. And I think probably most people on this webinar, listening to this webinar, know that it's jointly administered by the states and the federal government. In California, it's administered by the Department of Healthcare Services, and at the federal level, the Centers for Medicare and Medicaid Services, CMS. Funding is also shared by the states and the federal government, and there's a match rate that applies to each state, and it depends on the state's relative personal income. So California qualifies for the 50% match rate, which essentially means that for most program services, the federal government pays half and the state of California pays half. And importantly, in terms of Medicaid financing rules, there's no cap on that amount of money that the federal government will match. The federal government matches all eligible claims that is submitted by the state of California at the 50% rate, but there's no overall limit on it. So if we go to the next slide, please. So to receive federal Medicaid funds, states must follow certain requirements. And I should state the obvious or the implication from that, which is states don't have to join the Medicaid program. But if they join and they want to get their 50% match in the case of California, then they have to do certain things. They have to cover certain mandatory groups. Low-income children, for example, is a mandatory group, or mandatory benefits. And nursing home care, for example, is a mandatory benefit under the federal law. Without a waiver, a state has lots of flexibility. In the area of eligibility and benefits, it has considerable, though somewhat constrained flexibility to go beyond the federal minimum standards, subject to federal parameters. For example, while there's a minimum group of children that have to be covered, minimum income levels, a state can go and cover children at higher income levels if it chooses to do so. Those are optional eligibility groups. And on the benefit side, while I said that nursing home care was mandatory, home and community-based services to provide long-term services and supports is optional. And so that gives you a sense of there's a sort of basic requirements in the program, but state options both on the eligibility and the benefit side that states can take advantage of without resorting to a waiver. Similarly, without going to a waiver, states have pretty broad flexibility to design their delivery system and their payment rates, how much they're going to pay providers, healthcare plans. Again, subject to federal parameters, but pretty broad authority. For example, the rates paid to managed care organization in California are left to the states left to the state to determine, but it must be under the statute actuarially sound based on data, and state and federal government CMS will review the rates to see if it's been certified by an actuary and if it meets CMS requirements on actuarially sound rates. But as you might imagine, and you may know, the rates will vary a lot from state to state. So actuarially soundness does not determine what the rate will be, but just really a methodology for calculating the rate, and that's the limitation imposed by federal law. Waivers, so those are the basic rules. Waivers, however, can provide some additional flexibility and funding. So let's get into how you get to tell the federal government what it is you're doing and what it is you want. If we can go to the next slide, please. So state plan amendments and state plan amendments. The state plan really is the way that a state lets the federal government know, and the public, it is a public document, although sometimes hard to to make your way through it. That the state is in fact covering the mandatory populations and mandatory benefits, and it also is the way for a state to tell the federal government what options it's picking up or dropping at any given time. So it is, and this is the official definition, it is the agreement between the state and the federal government describing how it is going to run its Medicaid program. And it is often amended, right? And those are fondly known as SPAs, state plan amendments. And approval of a SPA, and this is important as we get into the differentiation between state plan amendments and waivers, approval of a state plan amendment is really not discretionary with the federal government, meaning a state has options that they can choose to pick up and options that they can choose to modify, options that they can decide to drop. And as long as in doing so, the state is following the federal rules, the decision to pick up an optional benefit or drop an optional benefit, which is executed through a state plan amendment, is really a state choice. And the federal government reviews to make sure that the benefit that they're picking up is done consistent with federal law, but the ability of a state to pick that option or to drop that option belongs to the state and is not subject to federal determination. So for an example, if you look at the examples of the kinds of SPAs that happen frequently in any given state, if you look at a benefits SPA, dental benefits for adults are an optional benefit, not for children, but for adults. So if a state wanted to take up a dental benefit for adults, it would do a state plan amendment to tell the feds and to tell the public, yes, I am now covering dental benefits for adults, and here's the nature of that benefit, and here's how I'm going to pay for it. Similarly, if a state decides it's no longer going to do dental benefits for adults, it would submit a state plan amendment to delete that part of the state plan and to no longer cover that benefit. So let's go to our first example of waivers. So there's a couple of different kinds of waivers in the Medicaid program, and I'm going to talk about 1915 waivers and then Section 1115 waivers. So 1915 waivers do exist in California, and Jen will talk about it, but they are limited in scope. So they are Medicaid-specific waivers that allow states to do certain things, and it's mostly about giving the state authority to limit the providers that will be paid to offer a particular service, or that a beneficiary can turn to for a particular service. So you can do, a state can do mandatory managed care through a 1915 waiver. I should also say, just to keep you confused, is that you can do mandatory managed care also through a state plan amendment, but the waiver gives the state a little bit more flexibility than what the state plan option offers. So they're pretty common waivers, 1915 waivers. There are also ways to do home and community-based services, one of the optional services that I talked about before. And California has both 1915B and 1915C, which is the home and community-based waiver services. Review and approval is not automatic, but it is relatively routine because the discretion is granted, but it is a bit limited. So you can do certain things under 1915B and certain things under 1915C waiver. A state says, here's what I'm going to do, and the federal government reviews it. They're usually good for 2 years, 2 to 3 years, and then they're renewed, and often they are regularly renewed. And a state may have a 1915B or a 1915C waiver for decades, sometimes with changes and sometimes staying close to what the original was. So I think I ran through some of the examples. So why don't we go to the next slide and look at Section 1115 waivers. So usually when you have a conversation at a dinner party and you talk about Medicaid waivers, it's probably that you're talking about Section 1115 waivers, or that you need a rest. So they are the bigger, more comprehensive waivers that are available, and they're actually not even limited just to the Medicaid program. The Section 1115 refers to the section of the Social Security Act which is broader than the Medicaid program, includes but not limited to the Medicaid program. And that's the section of the law that authorizes them. And what Section 1115 does is it gives the Secretary of HHS, of the Federal Department of Health and Human Services, the authority to approve demonstration projects, and that's what they're called officially. They're known as waivers, but they're demonstration projects that allows the state to use funds or to design their programs in ways that otherwise you couldn't do under the law. Right? So you're either trying to do something that the law says this is not the way to do it if you're going to get Medicaid programs, so you're trying to waive that provision of law, or you're trying to get dollars to be used in ways that aren't otherwise authorized by federal law. They can be pretty narrowly drawn, but for the most part, when a state goes through the trouble of asking for a Section 1115 waiver, they tend to be pretty comprehensive, meaning they may make significant changes to the program or provide significant new authority to the funding to the state. So unlike the state plan amendments, waiver approval, Section 1115 waiver approval in particular, is discretionary. Each administration decides really the kind of waivers it's interested in approving, and there are also guidelines that exist in law as well as tradition. So let me go to the next slide to just talk a little bit about those constraints and how the discretion is defined under the law. So broad authority, but not unlimited authority, and it must be an experimental or demonstration project, meaning it's not supposed to be forever. It's supposed to be tested as a different way of doing things. And a key provision of the law is that the Secretary's discretion is limited by what the Secretary determines furthers the objectives of the program. And that is a very important principle, and we've seen it being played out right now in the courts as the federal government has approved some waivers, for example, on work requirements that had never been approved before. They have been challenged as to whether the Secretary really had legal authority to grant those waivers, particularly calling on the question of whether it furthers the objectives of the Medicaid program. So that's the overarching limitation, but there are also some other limitations in the law. For one, there are certain parts of the program that can't be waived. For example, you could imagine every state would come into the Secretary and say, please, I'd like, instead of a 50% match rate, I'd like a 100% match rate. So that's put off limits, and the Secretary doesn't have any authority to change the matching rate or the rules around match. And there are certain other limitations in the statute as to what can be waived by the federal government. But most of the provisions can be. An example that you might want to, example that you can't, of something that you can't waive besides FMAP is cost sharing. There's a very specific provision in the statute that allows very limited, so I shouldn't say they can't be waived, but very limited authority for the Secretary of HHS to waive the statutory cost sharing rules. And then by long-standing practices, this is a really important constraint on the waiver authority, is that the federal government, meaning it's not in law and it's not in statute, so it's by practice, is the federal government won't approve a waiver unless it determines that it won't cost the federal government anything more than what the program would have cost the federal government without that waiver. And so there needs to be a promise of savings or some kind of offset to the cost if the waiver itself would on its face carry some cost. And sometimes states have stored up savings in their waiver history, and they can often use that as a way to draw down some additional dollars on a new waiver or a waiver amendment. We can get through, talk about budget neutrality questions if people have them later on. So let me get to what those waivers actually have looked like over the years. If you look at the trajectory of waivers, they have really changed. The nature of the waivers change from time to time because the healthcare landscape is changing and because what states are interested in or what the federal administration is interested in will change from time to time. And so you see that in the mid-90s, that was before states had the authority to do managed care through a state plan. A lot of the waivers were to let states do managed care. That was really the beginning of the implementation of managed care into the Medicaid program, and states often used 1115 waivers to accomplish that goal. And some of them, this was before the ACA, before states had the ability to cover childless adults except through a waiver. Sometimes states were using some of the savings for managed care, remember budget neutrality, to start covering single childless adults. So you can see here that those policies have evolved over time as the healthcare dynamics have changed, as in the case of the advent of managed care, and as state interests have changed, and with each administration. Each federal administration often has their own priorities. So let me talk a little bit before I end about where we are now on federal priorities for 1115 waivers. You'll see that some of the policies that we see implemented in 1115 waivers through the current administration are what I think of as holdover policies, ones that are not inconsistent with policies that the previous administration or maybe several administrations have had, and some are new. So in the area of a new policy, work requirements and other conditions on eligibility that wouldn't be otherwise authorized by law have been approved through Section 1115 waivers, and we talked a bit about the litigation and some of the controversy about whether the Secretary has the authority to approve some of the work requirement waivers. The last administration, the Obama administration, approved a number of waivers called DSRIP, Delivery System Reform Waivers, that provided states some additional dollars as they were trying to transform their delivery and payment systems. This administration is phasing out DSRIPs, or appears to be phasing out DSRIPs that states have had in the past, as well as other sources of funding that have provided through waivers around uncompensated care pools. So it's continued the pools, but under some different rules. This administration has been approving some waivers to support investments in social determinants of health, how to help people with housing or hunger or violence issues as part of the delivery of Medicaid. Some of the interventions wouldn't otherwise be allowed to be paid for with Medicaid dollars except through the authorization of waivers, and we've got some of that in California as well. They're both the new administration and the last administration were beginning to also be more attentive to some financing constraints on waivers. I mentioned before on budget neutrality that sometimes you can use stored up savings. If you did managed care for 20 years, maybe you think you've saved the federal government lots of money through your managed care waiver, and then you want to use that for a delivery system reform investment. The federal government will still allow you to think about that, but they won't. They're rebasing those savings, so you can't really store up those savings for decades at this point. They will take a more truncated look at those savings. And then this current administration is considering block grant waivers and issuing guidance that would encourage states to do block grant waivers. If that comes out, that would be a new initiative on 1115. Finally, let me just mention, because this is particularly relevant for all of you in California as you're about to go through some changes on waivers and waiver processes, there is a requirement by law that there be public transparency. You can do some significant changes. You, a state, can do some significant changes through a Medicaid waiver. And in the ACA, there were changes to the waiver policy to say, well, let's make sure that there's a chance for the public to know what changes are being considered and to have some opportunity to provide public input. So there is both a public comment process, so the waivers have to be posted at the state level, and an opportunity for comment and hearing at the state level before the state can submit a waiver to the federal government. And then once the state submits it to the federal government, there is a public process and comment period at the federal level. So with that, let me turn it over to Jennifer Ryan, who will take you into a bird's eye view of California's waivers.
Great. Can everyone, hopefully people can hear me. Thanks to CHCS for having us today. Really looking forward to this presentation and the discussion and your questions that will follow. So my task today was to talk with you more specifically about the role of waivers in California. Cindy laid out a really excellent foundation for the discussion that I'll go through here regarding California. You know, there are a lot of things, there's a lot of sayings around the Medicaid policy community about Medicaid. And one of them is, if you've seen one Medicaid program, you've seen one Medicaid program. That certainly applies to California, maybe more acutely than any other state in some ways. And another saying that I've always really liked is that states serve as the laboratories for innovation in their Medicaid programs. And that's something that I've always thought about in my long history working on this program. I've worked on Medicaid for my whole career and have seen a lot of really interesting and innovative things happen, both nationally, but certainly in California as well. So in that vein, to just kind of move to what I'm going to talk to you about today, I'll spend some time talking about the history of the waivers in California, both the Section 1115 waivers that Cindy talked about, as well as the 1915B waiver authority that's been used here in California. And then I'll talk with you a little bit about what to expect for the future in this coming year. Want to go to the next slide? So as you can see here, and mimicking a little bit Cindy's national version of this slide, California was one of the first states to get into the waiver business back in 1995, both with an 1115 waiver in Los Angeles County, as well as the use of a 1915B waiver authority to begin consolidating its mental health services at the county level. I'm imagining that many of you guys were in junior high when these first waivers were approved, but this was around the first beginning of my career in Medicaid, and so I remember the Los Angeles County waiver in particular as a really big deal, and really was the first experiment of this nature. So as you can see from the timeline, the Los Angeles County waiver did get renewed in 2000, so it ended up being a 10-year long demonstration, and then it kind of shifted on to other things at that point. But California had clearly kind of gotten hold of the value of waivers and was starting to see some of those savings in managed care that Cindy talked about, and really was trying to also direct funding toward the public hospital system in California. So as you can see, between 2005 and 2010, there were some really significant efforts to shore up the public hospital system and state budgets. Thanks, yep. Getting ahead of myself there. And you can see that, it was very important to make hospital care more efficient and provide some needed funding there. And the result of the uninsured waiver was to really shore up state and county budgets as well. And then in 2010, the state kind of shifted over and started really taking advantage of some of those administration priorities that Cindy talked about, and was the first state to receive approval for a delivery system reform incentive payment program waiver. It was a very large sum of federal funding that was infused into the state and through the public hospital system. And that waiver really started the process of innovation around quality improvement efforts and performance measurement. Part of the bridge to reform was also to adopt the early expansion of the Medicaid expansion. So that took effect in 2012, which made California one of the earliest states to make that expansion to low-income adults. And then in keeping with kind of the real evolution of managed care as a delivery system in California, the Bridge to Reform waiver also had the first authority to transition elderly and people with disabilities into mandatory managed care. So that was another groundbreaking effort that occurred in California. That's definitely worth noting. The last thing that was part of this really groundbreaking Bridge to Reform waiver was the creation of the drug Medi-Cal organized delivery system. That's important to note because it was California was the first state to receive this waiver authority, which is designed to provide federal funding to states to provide residential substance use disorder treatment in what are called institutions for mental disease. But The point is it's a residential facility that previously has been ineligible for Medicaid funding. And the idea behind these waivers is to really provide additional support to states in fighting the opioid crisis. So California is the first state to receive approval for that and has really served as a model for the nation on those issues. And then there are a number of programs that were also approved under the Bridge to Reform waiver that we kind of consider to be legacy programs, meaning they're still technically operating under waiver authority, but they're somewhat independent. So there's the CBAS initiative, the Cal Medi-Connect Coordinated Care Initiative, which is a very large and successful initiative in California, again, focused around providing managed care and integrated care for dual eligibles, individuals who are eligible for both Medicare and Medicaid. There's been some great work done in San Mateo County and through the Inland Empire Health Plan there. So CCI has been a really groundbreaking model for the nation as well. And then the other program to mention is the California Children's Services Program, which is a really successful program that's been focused on providing services to children with special needs. So getting to Medi-Cal 2020, which is present day, we, in the end of 2015, the states received approval from CMS for the Medi-Cal 2020 waiver. It served as both an extension of Bridge to Reform in many ways, but then also had some really new and innovative pieces as well. So I think one of the most innovative things really happening nationally is the whole person care pilots. These are county-based initiatives that are providing funding to coordinate behavioral health, primary care, social services, housing, food supports, all different things operating at the county level. And it's really a collaboration between health and social services agencies in a way that's not been done in many other places. There's currently 25 pilots in operation. There's some really great work going on, and I think it's also notable because the wraparound services that are provided through whole person care are really getting at those social determinants of health that Cindy talked about, providing access to housing supports through Medicaid, which was kind of groundbreaking. And then also the emphasis and a really successful part of whole person care has been the funding and support of sobering centers and respite care. So really putting an emphasis around trying to focus on folks at the ground level who have behavioral health needs and are at risk of homelessness or are homeless. So whole person care has been a really important and successful program for the past 5 years, almost 5 years. The other big element of Medi-Cal 2020 is what's called the Public Hospital Redesign and Innovation in Medi-Cal, or PRIME. And PRIME is a continuation with a different name of the district program from the Bridge to Reform waiver. The differences around PRIME, it continues to put a huge investment of federal funding into the public hospital system, but PRIME grew the program by adding the 35 district and municipal public hospitals to the PRIME effort. And so hospitals, receive this funding based on their performance on a series of clinical project metrics. So each hospital selects a number of projects to work on and then is required to report on their performance on those metrics. And it's been a very interesting experiment, something I've been quite involved in over the past few years. And I think the folks at the hospitals have really experienced a change in their culture around the focus on quality improvement. So it's been a really interesting and, again, innovative effort that will hopefully continue beyond the waiver. Next slide. And then Cindy mentioned the use of uncompensated care pools to provide support for the uninsured in various states. And the Global Payment Program is an example of that. As you can see, the payment program is a pool of funding that is based on a combination of the state's disproportionate share hospital allotment, which is disproportionate share hospital is funding that's been in the Medicare and Medicaid statutes for, I think, almost forever, that provides pools of money available to states to distribute out to hospitals to help cover their uncompensated care costs. And so that Global Payment Program has been a really critical part of supporting the counties in the public health care system for those remaining uninsured in California. And then the fourth big element is the Dental Transformation Initiative, and that's another incentive payment program trying to increase preventive services for children through oral health care, and really kind of aligns with some of the goals of the federal dental initiative that's underway. Next slide. So I've already mentioned the drug Medi-Cal organized delivery system, but this is just a little more detail around it. There are 30 counties participating in drug Medi-Cal right now, and together they provide access to treatment and prevention services for substance use disorders to about 93% of the state's Medi-Cal population. So even though it's limited to a certain number of counties, those are the populations, the counties with the highest populations that are in need of services. The program is administered through a county-based behavioral health managed care system. So that's one of the things that's quite unique in California is really across the board, the role of the counties. It is a, there are plenty of states that have strong county systems, but California may be the most unique in that front. And so that waiver expires at the end of December 2020 as well. So as you can see, we're coming up on an important year for the programs and to see where the future takes us. Next slide. Okay, so then I'll talk a little bit about 1915B waivers in California. So as Cindy mentioned, this waiver authority is a little more routine, a little less complex to set up and finance. And so, but again, California has been in the waiver business and is committed to it for a long time. And so California used this waiver authority dating back to 1995 when it first put psychiatric inpatient hospital services into county mental health departments. So again, that emphasis on the counties and the focus on really local control as well as financing structures. So that was the first waiver. And then in 1997, the state got a renewal of their first waiver to further add services to the county mental health plan, broadened it quite significantly in that second waiver, and also started focusing on consolidating specialty mental health services, which has become a really important issue as things go forward. Next slide. And so in 2000, the state did, in fact, complete the consolidation of their specialty mental health services into county mental health plans. And as you see here, enrollees who can meet the medical necessity criteria for those types of mental health services can receive a set of services through that mental health plan in their county. This waiver, as Cindy mentioned, the renewal of these waivers is a little more routine. This waiver has been renewed 9 times in the last 10 years, or I'm sorry, 20 years. And again, has right now the state has requested an extension so that it also aligns with the end of the Medi-Cal 2020 waiver and will provide a kind of a glide path to what's going to be happening under Cal AIM. Next slide. I'll just quickly touch on 1115 budget neutrality. Cindy already went through this, but it is playing an important role, I think, in the discussions around the future of Medi-Cal in California. As Cindy said, the structure of budget neutrality is by policy. It is not a statutory requirement, but it has always been a core part of 1115 waiver negotiations between CMS and the states. And states have historically been able to use the savings generated from the one waiver initiative to pay for other waiver initiatives. So as Cindy mentioned, using those managed care savings to pay for coverage expansion to low-income adults or other populations. California is one of the states that did rely on these managed care savings quite heavily, and it was really an important vehicle for financing a lot of the successful coverage initiatives that have taken place in the past decade. And so the change to CMS policy around budget neutrality has had an impact on California. It has caused the state to rethink the way that the use of the waiver authority and whether it's still the best way to go, frankly, because the loss of this savings has really caused the state to have to limit its initiatives under the waiver authority. I think the other thing, though, to say is that while that budget neutrality policy change has been important in the state's considerations, I think they too are also at a place where, California is often cited as having a very mature managed care program, managed care delivery system. And, when you think about the core use of the 1115 waiver authority, we talk about it as a demonstration or a research project. And I think there's also an argument to be made that after all these years that the research value has been proven in many cases, and so now it's time to broaden some of these initiatives into a statewide approach. So looking to the future, as mentioned, the four main initiatives, most of the initiatives going on right now all expire at the end of December 2020. So it is time to sort of start to think about things in a different way. I just mentioned that the state is definitely trying to think about how to move and to leverage its mature managed care system in a more statewide way, and rather than moving away from county by county different pilots and demonstrations and different adoptions of initiatives. And really the focus is improving care coordination for residents with the most complex needs and addressing the social determinants of health. Those are, nationally, I think, two of the really big issues in the Medicaid discussion today. So you'll hear about CalAIM next week, so I'm going to keep my remarks about this quite short. But as you've picked up, there definitely is need for a 1115 waiver renewal request, but it will be much more limited. There are lots of considerations going on, and the state is instead considering and planning to move a lot of what has previously been covered under 1115 into that managed care waiver authority under 1915B. But that all said, I think the other big priority for the state is that they want to sustain and actually scale many of the efforts that they started under Medi-Cal 2020, as well as the Bridge to Reform. So what to look for next steps? I imagine most people have heard about the CalAIM stakeholder engagement process that's about to launch. It will be starting with a series of work group meetings. There's going to be 5 work groups underway simultaneously between November and February, November 2019 and February 2020. The state will also be working on that 1115 waiver renewal request in the early spring and summer, really though informed by the discussions that happened during that stakeholder engagement process. And then simultaneously to that, the state is also working on that 1915B waiver submission, all of which will head over to CMS probably in the early summer of 2020. So we didn't talk about how long it takes to negotiate waivers. It can take some time, so we're making assumptions about a quick review process for this 1115 waiver in particular, because it will be fairly straightforward, but still assuming at least a 6-month review period, and hoping that CMS will agree to meet that deadline at the end of December 2020 for the final approval of everything. And then, of course, working with all the critical partners at the ground level, managed care plans, counties, providers, advocates, all the stakeholders that have an interest in the future of the Medi-Cal program, and the state will continue to really honor that commitment. So I think we might go to Catherine, right? Thank you.
Thank you both, Cindy and Jen, for your excellent presentations. It's hard to be both succinct and comprehensive, and really appreciate you doing both today. Our first question is, why are some waivers, like home and community-based services waivers, renewed repeatedly instead of being made part of the state plan, especially when the federal government determines that they are cost effective? So I'm going to direct that one to Cindy.
So there's different authorities you can now do. It used to be that you couldn't really do much in the way of home and community-based services other than personal care services, except through a waiver. But the statute has been amended so that there are now different options for states to do home and community-based services through a state plan. And there's a couple reasons why some states prefer to keep their waivers. One is that under a state plan authorization in general, you have to, however you define, the state define your home and community-based services, you have to serve everybody who meets that definition. Under a waiver, states are allowed to cap the number of people that they serve. And so many states, because of the cost of home and community-based services and long-term care, have chosen to continue waivers that allow them to cap. There also may be some additional flexibilities that you can do through a waiver beyond enrollment caps, but I think for home and community-based services, the caps are one of the key reasons why states have maintained those waivers.
Great, thank you. The next question, and I encourage, we have several hundred participants on today's webinar, so I encourage others to write in questions if you have them, but we're getting plenty. If in 1115 waivers innovations are found to be successful, then how do they get carried forward? How do they get carried forward over time if the activities would not have otherwise been allowed under federal law? In other words, how do we get beyond continuing to approve these through waivers and integrate them into Medi-Cal? It's sort of a, I think, another variant of the question that we just had. So let me ask, pose that one to Jen.
Sure. I mean, I think California is a good example of that, right? That when they first started using the 1115 waiver authority back in the early 2000s, some of the options, for example, around managed care were not available. The Balanced Budget Act passed expansions of managed care authority. The Affordable Care Act built further. The federal government put out regulations around managed care for the first time in a long time in 2016. So some of the options that were available to California back in the early 2000s are no longer, are they are now. And so I think, to my point earlier, the state has decided they're going to take advantage of those options outside of the waiver authority.
Great, thank you, Jen. Sydney, I'll direct this one to you. Can you provide more detail on the back and forth process on waiver and state plan amendment approvals between CMS and the state?
Sure. So let me start with state plan amendments. So I said that there's a limited amount of discretion at the federal government side. The state submits a plan and a plan amendment and thinks that it's satisfying federal requirements. The federal government reviews that state plan proposal, that state plan amendment proposal, and it has 90 days, there's a clock, 90 days to review and determine whether or not it's approvable, approve, or deny it. It can stop that clock once by asking formal questions. But what usually goes on is a lot of informal questions back and forth if it's a complicated state plan amendment and the federal government has issues. But ultimately, it needs to be determined within that 90-day clock, allowing for the clock to stop. If there's a formal question asked, you can only stop the clock once, and the state can put it back on the clock when it responds to the question. And if the feds don't comply with that time frame, then it is deemed approved. So there is often back and forth conversation, sometimes with the regional office, sometimes with CMS central office. Sometimes a set of questions that go back and forth. Sometimes it's just a very straightforward state plan amendment, and there's not a lot of questions to be asked or answered. In a waiver, states sometimes submit concept papers first to the feds to start getting conversations going about what the state's interested in, what the federal government thinks about what the state may be interested in, and that can help the state as it continues along the process of getting stakeholder input and considering how it wants to proceed with a particular waiver proposal. Once it submits the proposal, the trajectory is usually a series of meetings between the state and the federal government to go through aspects of the waiver and to make sure the federal government understands what the state is proposing. And often what you see in a proposal isn't what you get at the end of the day. I was sort of smiling when Jennifer was recounting the history of California being the first DSRIP waiver. It's absolutely true. It didn't ask to be the first DSRIP waiver. It was seeking to have funding for its public hospitals, which was a tradition of California's of using the 1115 for that purpose. And at that point, the federal government was beginning to think about, well, if we're providing dollars for delivery system transformation or for uncompensated care, maybe there should be some metrics and some goal set as to what that transformation should look like and what happens, what the objective is towards the end of that effort. And so that's really how DSRIP began, is imposing, frankly, some conditions on the request that California made to continue its funding for public hospitals.
Great, thank you, Cindy. Our next question is asking about the difference between the cost effectiveness requirements and budget neutrality. So I'm going to direct that to you again, Cindy, and also tie into that. You mentioned in your presentation, I think you put budget neutrality as a long-standing practice. So maybe if you could add whether or not it's a practice or it's actually a formal requirement.
Well, it is let's start with that. It is a formal requirement in the sense that, any description that the federal government puts out about 1115s and whatever, we'll talk about budget neutrality, and it is very much part of every 1115 that has been approved. It is not required, however, to be a formal requirement by federal law or by federal regulation. So it is really a federal government self-imposed requirement that these waivers be budget neutral. And I should even be more precise about that, because it's not that they be budget neutral for the Medicaid program, but for the federal government, but they have to be budget neutral for the Medicaid program, for the federal government's expenditures in Medicaid. So if you're trying to do a Medicaid waiver that might save money in Medicare, for example, you can't use those savings for your budget neutrality calculations in 1115. But let me just explain a little bit about budget neutrality. It does not require only that you have savings carried over. It's one way a state can meet its budget neutrality requirements is, oh, I saved you so much money years past, federal government, now I'm going to spend that, so give me some delivery system reform dollars or give me some dollars for an uncompensated care pool. That's where the federal government has constrained how far back it will rely on those savings, how long ago those savings can be, how old those savings can be for a current waiver. And both the last administration and the current administration were working on constraining those old savings being carried over for decades. But there are other ways you can also achieve savings in budget or achieve budget neutrality, even if you're trying to spend more money in a waiver. One is that if the waiver is also saving some money. So if you're doing a new initiative around drug treatment or integrating behavioral health and physical health, and you can make a case, the state can make a case that that's going to save the federal government money, in which case give me a little of that savings or give me all of that savings in this waiver to do something else that would spend money. So it's very much a negotiation between the federal government and the states about what a state is trying to do. States will try and make the case that it meets budget neutrality requirements because they have old standing budget neutrality savings stored, because they're looking for also including ways to save money in that waiver. And sometimes budget neutrality can be met simply because a state is trying to do something which it probably could have done without a waiver, and so that's not seen as a coster in budget neutrality. It's seen as what's called a pass-through or a hypothetical. So there's lots of different dimensions to budget neutrality. It's a complicated area, made more complicated by the fact that it's not set out in statute or regulation. So you kind of have to learn it by watching what goes on between the states and the feds over the years.
Great. Thank you, Cindy. We have lots of questions, but time for only one more before I hand things off to my colleague, Catherine. So I'll direct this one to you, Jen, since you're involved with the Cal-AIM process. How, now that people have the vocabulary and they can participate in these dinner parties that Cindy is going to, how can I get engaged with California's waiver renewal and Cal-AIM process?
Thanks, Chris. So as I mentioned, the formal stakeholder engagement process and work group process will start in early November. And all of those meetings are open to the public. There was a selection process for members of the work group, and that process has been completed. But there is, a limited amount of space for the public to participate. I believe there's also going to be phone lines if folks want to call in and listen to the discussion. And so that's the beginning of that engagement process. That is not formally considered the waiver renewal public process that Cindy mentioned in her presentation. That will take place after the waiver renewal request is developed. So likely in the spring. You might hear about one of the Stakeholder Advisory Committee meetings, the SAC meeting, focusing in on that waiver renewal request. And then there'll likely be another separate public hearing that's just dedicated to that process. So, yep, lots of opportunities to follow along. The CalAIM website is up and running, and there's ongoing information available there as well. So feel free to keep up through that process too.
Great, thanks, Jen. And again, let me thank you both before I now hand things off to my colleague, Catherine Tier.
Thanks, Chris. I'm Catherine Tier. I'm Associate Director of High Value Care here at the California Healthcare Foundation. And I focus in particular on how Medi-Cal cares for people with mental health and substance use disorder needs. We know that many people with mental health illnesses and substance use disorders too often don't receive care for these conditions, and also that failure to receive high quality care means often that they have poor physical health outcomes as well. And as you heard from Jennifer, both of California's big waivers that expire next year address behavioral health issues. So, as Jennifer also said, what happens to programs like whole person care, the drug Medi-Cal organized delivery system, both authorized under our 1115 waiver, is very much in play. And how best to advance integration of physical and behavioral health care services under our 1915B waiver is also going to be up for discussion. Given the importance of all these issues, the California Healthcare Foundation is planning a briefing upcoming in the next couple months on behavioral health integration in Medi-Cal. We don't have a date yet, but we will let you know by email when that is scheduled. And that'll be in person in Sacramento, but as always, it'll be available by live stream and by recording. We do our best to always set our briefings up so that they are available to people who want to join remotely. So you can see the slides and you can use the Q&A function. It'll look a lot like this webinar if you join remotely. And we encourage you to either come in person and come meet us for lunch, or else join remotely if that works better for you. At the end of today's webinar, we'll put a link to the evaluation in the chat window, and you can also find that in the meeting documents section of your screen. We really, really hope you'll fill it out. That's how we choose our topics for future events and make sure that the content that we're offering is useful. So please just take a couple of minutes to let us know what you think. And as Chris mentioned at the beginning, you can find the slides for this webinar also in the meeting documents section. We'll post a recording of this webinar and the slides again to our website next week. I also want to reiterate that we have a couple of short fact sheets on Medi-Cal waivers and on the state plan amendment process available on the website. And these are part of our larger series called Medi-Cal Explained, which might be a good resource for people who are interested in learning more Medi-Cal basics. As you've heard, the next few years are going to see a lot of changes in the Medi-Cal program, and we want to urge you all to be involved in shaping those changes. So just to reiterate a few of Jen's points, I encourage you to go to the CalAIM website at DHCS. If you haven't already, you can also, in addition to getting the schedule for the work groups, you can sign up for updates, and that would be the fastest way, for instance, to get the document that we hope to see on Monday with the initial CalAIM plan. I encourage you to participate in the work groups, to participate in the Stakeholder Advisory Committee meetings. The next one is on Tuesday, which you can do by phone or in person. And you can also, as Jennifer said, submit comments in writing where you have ideas or where you have concerns. So we hope this webinar has been helpful. I want to again thank Cindy Mann and Jennifer Ryan for sharing their considerable wisdom and their time with us today, and my CHCF colleagues who put the webinar together. And I want to thank all you for attending, for asking good questions, and for joining us this afternoon. Thank you.